All right, let's just jump right in. Welcome to this explainer on the anatomy, neurovascular supply, and clinical significance of the palatine tonsil. Look, if you're a first-year MBBS student, you already know this is one of those absolute must-know, high-yield topics. It's going to show up on your anatomy exams, and you're definitely going to see it in your future clinical rotations. So grab your notes, and let's decode the whole shebang together.
To keep things digestible, we're going to follow a pretty straightforward roadmap today. We'll start big with Waldeyer's ring, zoom into the boundaries and the tonsillar bed, check out the neurovascular supply and histology, and then wrap up with some crucial clinical significance and a few rapid-fire MCQs.
So, Part 1. The Waldeyer's ring. Before we talk about the palatine tonsil specifically, we have to talk about its neighborhood, which is Waldeyer's ring. Think of this as an interrupted circle of lymphoid tissue sitting right under the epithelial lining of your pharynx. Now, why is it placed exactly where your air and food passages begin? Well, it's essentially your body's frontline security system. It's literally intercepting and fighting off all the microorganisms trying to sneak into your respiratory and digestive tracts. And this security perimeter has a few key players forming a complete circle of defense. Up at the top, the posterior superior part, you've got the pharyngeal tonsil. You probably know those as the adenoids. Anteriorly, down at the base of the tongue, is the lingual tonsil. And then guarding the lateral walls, you've got the tubal tonsils and our main event for today, the palatine tonsils. They're just sitting right there on the sides, acting like massive checkpoints for every single thing you swallow.
Moving on to Part 2, tonsillar boundaries and the bed.
Okay, so the palatine tonsil itself, it's this almond-shaped mass of lymphoid tissue tucked into the tonsillar fossa on the lateral wall of the oropharynx, right between the anterior and posterior pillars of the fauces. But here is a really critical clinical pearl. What you see when you ask a patient to open their mouth and say "ah" is basically just the tip of the iceberg. The actual tonsil is much bigger than it looks. It extends way up into the soft palate and way down into the base of the tongue.
If we take a horizontal cross-section, you can really see how it's perfectly sandwiched in there. Up front, anteriorly, is the palatoglossal arch, which naturally holds the palatoglossus muscle. And in the back, posteriorly, is the palatopharyngeal arch with the palatopharyngeus muscle. Our tonsils sit securely right in that resulting triangular space. Now, what is it actually resting on? This right here is incredibly high yield for your exams. You absolutely need to know the layers on the tonsillar bed from the inside out. I like to use the memory trick PSB. First, the pharyngobasilar fascia. Second, the thick meat of the bed, the superior constructor muscle. And finally, the buccopharyngeal fascia on the outside. PSB. Definitely lock that one in your memory.
It also really helps to compare its two main surfaces. The medial surface is the one facing the open airway. It's covered by non-keratinized stratified squamous epithelium. And notice how it actually dips down to form these 12 to 15 deep little pockets, or crypts. The lateral surface, though, is completely different. It's bound by a fibrous hemicapsule, and just outside that capsule is a critical layer of loose areolar tissue called the paratonsillar space.
All right, Part 3, neurovascular supply and lymphatics.
So the tonsil is actually fed by 5 distinct arterial branches. You've got branches from the lingual, external carotid, and maxillary arteries providing some nice collateral flow. But honestly, if you only remember one thing here, remember that the tonsillar branch of the facial artery is the principal blood supply. That's the main powerhouse. And you can literally see how that main supply works mechanically. That tonsillar branch of the facial artery comes right up and enters the lower pole of the tonsil by directly piercing the superior constrictor muscle. Clinically, you'll want to remember this because it's a very common spot for post-operative bleeding in practice. Shifting gears to the lymphatics, the efferent vessels leave the tonsil, pierce that same superior constrictor muscle, and head straight for the upper, deep cervical lymph nodes. More specifically, they zero in on the jugulo-digastric lymph node. This is a massive takeaway for you. This node is so heavily involved that it's practically famous for it. Clinicians just call it the tonsillar lymph node. It sits just below the angle of the mandible, and in a patient with acute tonsillitis, you better believe it's going to be swollen and tender.
Let's zoom in further for Part 4, histology and development. If you throw this tissue under a microscope, it's unmistakable. At the top, you've got that non-keratinized stratified squamous epithelium, that purple border there, and watch how it just dives deep down into the tissue to form those narrow clefts, the crypts we talked about earlier. And right next to them, you'll spot these large, dense circular clusters. Those are the rich lymphatic nodules. They're basically packed with immune cells, just waiting to sample whatever random antigens happen to get trapped in the crypts.
Now, I want you to remember the number 2. 2 is the magic number here because the palatine tonsil develops directly from the second pharyngeal pouch during embryogenesis. And get this, the largest crypt in the tonsil, the crypta magna up near the upper pole, is actually a direct developmental remnant of that exact second pharyngeal pouch. Pretty cool, right? Which brings us to part 5, clinical significance. Let's make this real.
Remember that loose areolar tissue on the lateral surface, the peritonsillar space? Well, it's a total double-edged sword. On one hand, it's an absolute lifesaver for an ENT surgeon because it creates the exact surgical plane needed to cleanly dissect and remove the tonsil during a tonsillectomy. But on the flip side, because it's so loose, it's the path of least resistance. So if a tonsil infection spreads, this is exactly where the pus collects, creating a severely painful condition called a peritonsillar abscess, also known as quinsy. All right, final stretch, part 6, rapid revision and MCQs. Time to shift from passive listening to active recall.
First question, think back to our chat about lymphatics. What specific nodes are primarily enlarged during a tonsil infection? You know, the ones that earned the nickname tonsillar lymph nodes. Give it a thought. Yep, absolutely. The jugulo-digastric lymph nodes. Remember, they're sitting right below the angle of the mandible in that upper deep cervical chain. You're going to be palpating those a ton during your pediatric rotations.
Okay, let's level up a classic multi-step exam scenario. A patient comes in with severe tonsillitis, but they're also complaining of a terrible earache. What is the cause of this referred earache? Why would a throat infection make your ear hurt? It's all about crossed wires in the nervous system. This elegantly explains the pathophysiology of referred otalgia. The palatine tonsil gets its sensory supply from the glossopharyngeal nerve, cranial nerve 9, but the tympanic branch of that very same nerve also supplies the mucous membrane of the middle ear. So the brain gets confused about where the pain signals are coming from, and boom, the pain of tonsillitis is referred directly to the ear. As we wrap up this explainer, I want to leave you with a final thought to ponder. We know Waldeyer's ring is a vital protective barrier, right? But parts of it, specifically the adenoids, naturally atrophy and almost completely disappear by the time we hit 20 years old. So how do you think that massive change in our architecture alters our immune defenses as adults? It's kind of fascinating to realize our anatomy is never fully static. Keep questioning things, keep studying hard, and we'll catch you in the next explainer.